Hi guys, Assalamu alaikum. I hope every one of you is doing great. My name is Anis Fatma and I'm a final year medical student, and today we will be studying about the peritoneum together. So let's get started. So before starting the pathologies we might come across in the peritoneal region, we will look at the surgical anatomy of the peritoneum. So peritoneum is what? Peritoneum is basically a serous membrane which is lined by the mesothelial cells. It is present in the abdomen. It covers most of your intra-abdominal organs, and the peritoneal cavity is described as the largest cavity in your body, and the peritoneal membrane can be divided into two types: the parietal peritoneum and the visceral peritoneum. As the name themselves suggests, the parietal peritoneum lines the abdominal and pelvic walls and the inferior surface of the diaphragm, and it is innervated by the somatic nerves, and it is sensitive to the pain. It means whenever the parietal peritoneum gets irritated, you will experience the abdominal pain. Now, the visceral peritoneum is the layer of the peritoneum which lines the viscera. It is innervated by the visceral nerves and is relatively insensitive to the pain. Now, why is this peritoneum important? The functions of the peritoneum include the pain perception. If the organ gets irritated, it involves the parietal peritoneum. You will experience the pain. The visceral lubrication. For example, your intra-abdominal organs are undergoing peristalsis, the organs of the GI tract. So the friction would be produced. In order to minimize that friction, the visceral peritoneum is very important. The fluid and particulate absorption, the inflammatory and immune responses, letting your body know that if there's some kind of the foreign bodies present, and to initiate the inflammatory process to divert the attention of the body towards the problem, and then fibrinolytic activity, etc. The peritoneum can produce the inflammatory exudate when it is injured, and the common causes of the injury of peritoneum could be the bacterial infection, the chemical injury, ischemic injury, or any other trauma or allergic reaction, etc. So let's look at what is peritonitis. So peritonitis refers to the acute inflammation in the peritoneal cavity. In majority of the cases, it is caused by the bacterial invasion of the peritoneal cavity and is therefore known as the bacterial peritonitis. It is usually polymicrobial, and both aerobic and anaerobic organisms could be involved in this. So what are the sources of this bacteriology or the bacterial peritonitis? They could be the gastrointestinal sources like E. coli, streptococci, clostridium, etc. The gram-negative non-spore forming organisms which are found in the lower intestine could also be included, and they are called bacteroids. They grow in the anaerobic media which contain adequate carbon dioxide tension, and that's why they are very resistant to the penicillin, and for that purpose we will use metronidazole whenever we will get the peritonitis case. So the causes of the non-GI tract peritonitis could be chlamydia, gonococcus, beta hemolytic streptococci, pneumococcus, and mycobacterium tuberculosis, obviously. The route of infection could include the gastrointestinal, the exogenous contamination, like for example when you are placing the drains, when you are doing the surgery, when some foreign body comes and produces the trauma in the abdominal cavity. It could be due to transmural bacterial translocation, like for example you have an inflammatory bowel disease or appendicitis. The bacteria travels through the blood and they enter into the peritoneal cavity, etc. The female genital tract infection, like the PID, could lead to this problem, or hematogenous spread obviously could be the source of the peritonitis. Now, peritonitis can be divided into two forms based on the location of where the peritonitis has been produced. It could be divided into localized and the generalized peritonitis. So, let's look at all of these one by one. Now, the factors that would aggravate the localized peritonitis would be if there is a formation of the adhesion somewhere, if there is stasis of the content of the GI tract, if there is greater momentum which is acting as a nidus for the production of the infection, or you have placed any external body, like for example you have placed the drains. The features of the localized peritonitis are: whenever you are experiencing the peritonitis, the initial signs and symptoms are those of the underlying condition. So they could be malaise, anorexia, and nausea. Like you don't feel like eating anything, you are feeling nauseated, you are feeling very tired, and then it can lead to the pyrexia, fever, or tachycardia. And then you will start experiencing the localized abdominal pain, and due to that irritation, it could proceed to the vomiting. And if it is diffuse peritonitis, it could also become localized, most frequently in the pelvic region. And the features that would suggest a peritonitis would be guarding. That's very important. What is guarding? It is the involuntary abdominal wall contraction to protect the viscous from examining hand. So whenever you are taking your hand for the examination, you will experience the rigidity and the resistance from the abdominal muscles that won't allow you to palpate the organs. Then there would be rigidity, which is involuntary abdominal wall contraction over the inflamed parietes, and the rebound tenderness. What is rebound tenderness? When you are placing your hand to palpate, the pain won't be produced, but whenever you are leaving your hand, the pain would be produced after you left your hand for the palpation. So that's called as a rebound tenderness. Then there is the shoulder tip pain if C5 dermatome is involved. If there is a localized tenderness of the subphrenic space, it could lead to the irritation of the phrenic nerve. And then we have the generalized peritonitis. Generalized peritonitis is produced जब आपका पूरा का पूरा peritoneum gets involved into the inflammatory process. So there would be it could be due to any factor, like for example in young children who have very small momentum, if the patient is in an immunocompromised state, like the patient of diabetes or AIDS, if the patient has been using steroids for a long period of time, etc. Now, the speed of peritoneal contamination is also very important. For example, if there is a sudden perforation, it could lead to the generalized peritonitis, and the cases of obstruction mostly leads to the generalized peritonitis in case there is a perforation there. So, how would you recognize if it's a case of generalized peritonitis? So, there would be the severe abdominal pain, which is aggravated even with your slightest of the movement. Why? Because whenever you are moving your peritoneum as well, it gets irritated and the severe pain would be elicited. Also, the pain is so severe that the person can't respire properly. He cannot take deep breaths because the peritoneum gets so irritated. Then there would be guarding and rigidity, nausea, vomiting, constitutional upset, tenderness, uh, it could lead to the septic shock, which could lead to the circulatory failure, and the patient might land in the emergency. How would you recognize if it's a circulatory failure or not? The person would have cold clammy extremities, the person would have sunken eyes, dry tongue, thready or very feeble pulse, and the person could have the drawn and the anxious face. So you have to look at the face of the patient. Then there are some of the investigations we can do. We can do the plain radiograph in the supine position to check if there are dilated gas-filled loops of the bowel, which might be due to the presence of the paralytic ileus. Then we will do the erect chest X-ray to see if there is a gas under the diaphragm, to see if it is a case of perforation or not. Then lateral decubitus position, where you can also do the radiograph to see if there is a gas beneath the abdominal wall. That could indicate towards the case of the perforation and the GI contamination of the peritoneum, which could have been the cause of the peritonitis. Then you can also check the serum amylase level to rule out if there was pancreatitis or not, full blood count to check if there was infection initially or not, C-reactive protein, ultrasound, CT scan, etc. Now, the most important test for the investigation of the peritonitis would be peritoneal fluid aspiration. If the fluid that you have aspirated out of the peritoneal cavity is bile stained, it means this might be the case of the perforated peptic ulcer. The bile gets entered into the duodenum. If the duodenum gets ruptured due to the peptic ulcer, it could lead to the bile stained fluid. It could be the perforated gallbladder as well. If there is a pus in the fluid, it could be bacterial peritonitis, and if there is a blood in the fluid, it would be intraperitoneal bleeding. And then we are moving towards the management. Now, the management of the generalized or the localized peritonitis would be the general care of the patient. You would correct the fluid and electrolyte imbalance. You would insert the nasogastric tube to do what? To decompensate the GI tract. You would start the broad spectrum antibiotic therapy to see if there was a bacterial peritonitis, and then you will give analgesia to the patient to relieve his pain, and you will check the vital signs. The specific treatment of the cause would be the operative management. For example, if you are doing the operative management, the peritonitis might be due to appendicitis, right? So you will do the appendectomy. If it was the case of perforated peptic ulcer, you will do the surgical closure of the perforation. If there was a diverticular perforation, you will resect the affected segment and perforate a tumor, so you will do the surgical resection of the tumor, etc. The non-operative management in cases of the peritonitis which are caused by pancreatitis, salpingitis, primary peritonitis which might be caused by streptococcus and pneumococcus, there is no need of surgery. You will go with antibiotic therapy and the patient will be cured. You can also do the peritoneal lavage. In this process, the peritoneal cavity is exposed with the sucker, and if necessary, it is mopped dry until all the exudate is removed. And in this process, a large volume of normal saline containing the dissolved antibiotic, like for example tetracycline, which is a broad spectrum antibiotic, can be used. There could be the several complications of the peritonitis, which could be the systemic complications or the localized complications. So, the systemic complications would be the shock, obviously, the endotoxic shock, bacteremic shock. It could lead to the bronchopneumonia because the organism that has contaminated the abdominal cavity could also goes via the blood to your lungs, and it could lead to the respiratory failure because the patient might be in a circulatory shock, and the renal failure if the blood supply gets impaired, then bone marrow suppression, multi-system failure, etc., etc. Then comes the abdominal complications or the localized complications. So whenever there is inflammation in the peritoneal cavity, it could lead to the formation of the adhesion. So the small bowel will develop the adhesions to its surrounding structures, and that could be one of the complications of the peritonitis. And it could also lead to the paralytic ileus, or it could lead to the abscess formation in the localized area, or it could lead to the pyma formation in the portal area, or it could lead to the liver abscess as well. So you have to start the broad spectrum antibiotics, you have to correct the electrolytes ASAP, and you have to decompensate the GI tract in case there is a perforation. You don't want to leave the contaminated contents into the GI tract. And then, as we studied, that one of the complications of the generalized peritonitis could be the formation of the abscess in various locations. So, the intraperitoneal abscess could be the pelvic abscess. This is the most common site of an intraperitoneal abscess because the appendix, which is the most commonly ruptured organ, is in the pelvic position, or the fallopian tubes, which are frequently involved in the infection in females, are present in the pelvic abscess. Uh, the pelvic space. So the pelvic abscess can also be caused by the sequel to any cause of the diffuse peritonitis, and the clinical features could include the severe pelvic pain, the diarrhea with the passage of the mucus. Note that this is very, very important. If there is a passage of the mucus in the stool, you will start with the broad spectrum antibiotics because it could be the case of the pelvic abscess. And then rectal examination would reveal a bulging of the interior rectal wall because there is obviously the abscess in the pelvic region. The management would include the drainage of the abscess. So, in women, the vaginal drainage through the posterior fornix is done, while in men, the rectal drainage is better. The drainage can be done under the ultrasound or the CT scan, so you might not damage the other organs which might be present in the surroundings. Then we have some specialized forms of the peritonitis, which could be the pneumococcal peritonitis, which is characterized by what? By the presence of the diffuse diarrhea over the 24 to 48 hours, and the when you are doing the aspiration, the odorless and sticky exudate would confirm the diagnosis of the pneumococcal peritonitis. And then we have the tuberculous peritonitis, and it can occur in acute or chronic forms. There could be the clinical features of abdominal pain, fever, night sweats, etc. The three different types of the tuberculous peritonitis would be ascitic form, encysted form, and the fibrous form. The fibrous form is also known as the plastic form, and then there could be the purulent form. So four types basically. It could be the ascitic form, encysted form, fibrous form, or could be the purulent form as well. And then one important topic in the peritoneum pathologies could be the ascites. What is ascites? It refers to the accumulation of the serous fluid within the peritoneal cavity, and it can be recognized clinically only when the amount of the fluid present exceeds the 150 ml. So when it exceeds the 150 ml, there would be abdominal distension, and you could recognize it on the clinical examination. Now, how the ascites develops? Ascites would develop as a result of sinusoidal hypertension. For example, the blood flows through the porta hepatis, and then it goes towards the liver. So if there is a hypertension in the sinusoidal capillaries which are present inside the liver, the blood won't be able to flow regularly. It would start accumulating in the vein, and then it could lead to the leakage of the fluid out of those capillaries, out of the vein, into the peritoneal cavity. Then there would be the decreased plasma oncotic pressure. If due to any reason the liver or the liver has stopped making the albumin, the plasma won't be able to hold the fluid inside the capillaries, and it could lead to the decreased plasma oncotic pressure, in turn the leakage of the fluid into the abdominal cavity or the peritoneal cavity. And it could be secondary hyperaldosteronism, which is causing the salt and water retention in your body, and that extra salt and water will go into the peritoneal cavity. It could be due to the splanchnic vasodilation. It could be due to the percolation of hepatic lymph into the peritoneal cavity as well. So the causes of ascites could be divided into two different types that include the transudative causes and the exudative causes. The transudative causes could be due to malnutrition, the nephrotic syndrome, the protein losing enteropathy, the congestive cardiac failure, the portal vein thrombosis, and due to cirrhosis. While the exudative causes, which are the ones in which pus would form. Okay, so the exudative causes could be the tuberculous peritonitis, the peritoneal malignancy, Budd-Chiari syndrome, pancreatitis, Kyle's ascites, Meek syndrome. All of these you have already studied in your medicine, so there is no need to focus on these. The main focus of studying peritonitis here is the treatment. So you would do what? You would do paracentesis abdominis to treat the ascites. It involves the needle drainage of the fluid from the peritoneal cavity, and then the fluid is sent for the culture and microscopy to be checked for the cell count, gram stain in culture, protein, cytology, amylase levels, etc. If the fluid is from the cirrhosed liver, it would be clear and straw colored. If it is due to tuberculosis, it would be straw colored or bloody. If it is due to malignancy, it would be bloody. If due to infection, it could be cloudy, etc. Now, the treatment would include the salt restriction, diuretics, large volume paracentesis, or the permanent drainage options like peritoneovenous shunts. Peritoneovenous shunt is when you are forming a one-way flow of fluid from the peritoneum to the central vein, like for example the internal jugular vein. The complications of it could be the overloading of the venous drainage system and the disseminated intravascular coagulation. And that's it from this chapter. We will be moving on towards the next chapter, which is known as the esophagus. See you soon.